Thank you very much. Assalamu alaikum, everyone. I'm going to talk about rheumatoid arthritis. I think on your brochure, maybe there is a different topic, but this is what I'm going to talk about. So these are the objectives of my talk. So by the end of the talk, I would like you all to have a basic understanding of the risk factors as well as the epidemiology of rheumatoid arthritis. I would like you all to be able to recognize the main clinical features and be able to interpret the common diagnostic tests. Then I'll talk a little bit about how do we manage rheumatoid arthritis, and I'll give you an update in the guidelines. And most importantly, I would like you all to be aware of the associated comorbidities with this disease. So as you all know, rheumatoid arthritis is a chronic inflammatory condition. It mainly affects the synovial joints. However, it has many extra-articular features and there are many comorbidities. This disease is managed by rheumatologists in secondary care. So the question is, what is your role? What is the role of this audience sitting here today listening to me about rheumatoid arthritis? Whether you're working in internal medicine or medical specialties or primary care physicians, how can you help me and how can you help my patients? So this is what I think you guys can help me with. I would like you all to be able to early recognize this condition and refer to rheumatology clinics, because we know that if we treat early and aggressively, we can prevent the long-term morbidity and mortality. You may need to deal with a patient who's come with a query, rheumatoid flare. We use a lot of disease-modifying treatments, and we use a combination of treatments. So maybe you have to deal with the complications relating from these medication. And most importantly, there are a lot of extra-articular features and the comorbidities that the medical specialties and internal medicine people can help us with. Talking about the epidemiology, it's a fairly common disease. About 1% is the prevalence. It is 3 times more common in females compared to males, and the incidence increases as people grow older. So in an aging population, you'll see a lot of rheumatoid arthritis. I would like to now present the results of a systematic review. Is anyone going to fix this? Okay. Shall I carry on? Okay, so these are the results of a systematic review which looked at 60 population-based studies, and it found that the prevalence was quite high in Northern and Western Europe, in different parts of America, and the prevalence was low in Africa as well as in Asia. So on the whole, it's more common in Caucasian countries and in countries where Caucasians have immigrated. But there's a lack of data. All of this gray area is where there's no data. So there's a lack of data in many parts. So we don't really know the true prevalence of this disease. This study also showed that the prevalence was much higher in urban countries, urban areas compared to rural areas, which indicates that there may be an environmental trigger for this disease. So what causes rheumatoid arthritis in the first place? Well, we don't really know. However, we think that there may be a combination of genetic factors, an environmental trigger, which leads to an aberrant immune response. So the genetic studies, particularly twin studies, has told us that the genetic disposition for rheumatoid arthritis can be as high as 60%. And the most common link is with the HLA DRB1 and DRB4. And then in a genetically predisposed person, there is something in the environment, whether there is a chemical or it's an infection or something else which just triggers the disease in that person. But if that person doesn't meet that environmental trigger, maybe that person will go through his life without even developing the disease. So the question is that if a person comes to you, he's maybe CCC positive, he doesn't have the clinical disease, he's got a strong family history of rheumatoid arthritis, and he may have type 1 diabetes or autoimmune thyroid disease, and he asks you, are there any modifiable risk factors that I can work on that may even delay the disease, or I may not get the disease? So these are the things that you can talk about. For example, we know that cigarette smoking is very much linked with CCP positive rheumatoid arthritis. And there is also a link with obesity. as well as a high caloric diet. So these are the factors that you can talk to your patients about. The pathophysiology of rheumatoid arthritis. So I'm just going to go over a little bit into the pathophysiology. This is a normal joint. So you can see that this is a healthy green cartilage. This is the fibrous capsule, and then you've got the synovium in the middle here. What happens in rheumatoid arthritis is that this synovium, it becomes proliferated, there is increased vascularity, and it causes almost this pannus-like, which is like a tumor-like structure. And this is what you feel when you touch over the patients with rheumatoid arthritis. Now, if the patient is not treated, this pannus can actually erode into the cartilage, and then it can erode into the bone. And when that happens, you get the deformities of rheumatoid arthritis. And by this stage, the disease or the deformity is irreversible. If we look at a cellular level, both T cells as well as B cells are implicated. So they become autoreactive. The B cells produce lots of autoantibodies, for example, the rheumatoid factor, the CCCP antibody, which travels into the joint and it drives the inflammatory process. The T cells produces the different cytokines. These are the inflammatory cytokines like the IL-1, IL-6, and the TNF-alpha. And then they continue with the inflammatory process. They also drive many other pathways like the rank ligand pathway, which stimulates the osteoclast, and it also produces some enzyme which eat up the cartilage and the bone, which causes the deformity of rheumatoid arthritis. And now that we know the pathophysiology, these are the important therapeutic targets when it comes to the biologic treatments. So the clinical features, now a lot of work has gone into raising the awareness of early recognition of this disease. And this is one of the posters by the Arthritis Research Campaign in UK. Do you have the S factor? So if you've got swelling in the smaller joints and there is stiffness, particularly in the morning, and there is a tender squeeze when you press over the joints, you're more likely you have rheumatoid arthritis unless proven otherwise. This is how they campaign it. And the very easy way of looking is that you just press across the bases of the fingers or press across the bases of the toes. If it's positive, always think about rheumatoid arthritis, and these are the patients we would like you to refer to our clinics. Typically, it has an insidious onset and characteristically affects the smaller joints of the hands and feet, and it's more proximal compared to distal. It's a systemic disease, so patients can have symptoms of a systemic disease like weight loss, fever, and fatigue. And you need to be aware of these atypical features as well. For example, sometimes patients can present with an acute monoarticular presentation, and sometimes this is difficult to differentiate between crystal arthritis and rheumatoid. Looking at the signs in early rheumatoid arthritis, you look for the synovitis, which is this boggy, squidgy swelling, which is warm and tender across the joints. So here you can see that there is swelling of the PIP joints here. You can see there is synovitis affecting the MCP and the PIP joints. And another feature to look for is the rheumatoid nodules, which are usually present on the extensor surfaces of the limbs, usually distal limbs and over the tendons. And later in the disease, which this is something we shouldn't really be seeing nowadays, is the deformities of rheumatoid arthritis. And by this stage, patients usually have muscle wasting, and they also have a reduced range of movement. So in addition to the articular disease, rheumatoid arthritis has many extra articular features. And the common one being the eye, for example, it can cause episcleritis, scleritis, as well as conjunctivitis. Another important extra articular organ that it involves is the lung. It can affect the pleura, as well as the interstitium of the lung, and sometimes it causes rheumatoid nodules. And these extra articular features are more common in patients who are seropositive. So it's important to know that rheumatoid arthritis is a clinical diagnosis, and the blood test can be entirely normal. So if someone you suspect has rheumatoid arthritis, the blood test is normal, don't dismiss this diagnosis. These are some of the common abnormalities which are found. So you can get an inflammatory response, the ESR, CRP can be high. And if this is high, it makes our life easy because we can use this to monitor the disease activity and also to the response to treatment. And then there are three important autoantibodies I would like to talk about. So rheumatoid factor is present in about 80%, but it can be present in other autoimmune diseases. It can be present in chronic infections. So not everyone who's got a positive rheumatoid factor has rheumatoid arthritis. And it's present in about 5% of the population. It doesn't relate to disease activity at all. Once you know the diagnosis, there's no point in repeating rheumatoid factor because that's not what's telling you whether the disease has got better or not. And if it is present, it tells us that this patient is more likely to develop severe disease as well as extra-articular features. Anti-CCP antibody is much more specific than rheumatoid factor, and it is present, the specificity is about 95%. And again, it doesn't change with disease activity. There's no point in repeating it. And it can be present years and years before the patient actually develops clinical disease. And it helps us to identify a cohort of patients where we need to do early and aggressive treatment. And the third autoantibody is ANA, which is not very specific. It's present in about 40% of the patients, but it's present in many other autoimmune diseases as well. Imaging-wise, X-rays are not very useful at the beginning. Patients need to have symptoms for at least 3 months before we can see changes on the X-ray. And if there are changes, there's usually periarticular osteopenia that you can see in the green circle. Then you've got the erosions, which is the punched out bone lesion, which is the bone being destroyed by the rheumatoid pannus. And then you also get the reduction in the joint spaces. Ultrasound is gaining a lot of popularity in the rheumatology clinics, and it is useful when to pick up subclinical synovitis when the diagnosis is not clear. So if you have a patient with a suspected flare-up, you're not quite sure what's causing the pain, you can do an ultrasound examination. And then lastly, we've got the MRI scan, but this can be quite costly. If you have access to the MRI scan, then it can quantify the damage from rheumatoid arthritis. So here you can see a lot of erosions, and sometimes these erosions cannot be visible on the plain X-rays. Now, disease activity tools, there are a lot of disease activity tools that we use not only to record, but also to standardize how we should be assessing patients. And this is one of them. This was called the D28 Score. It has 4 parameters. We look at the number of tenders, swollen joints, and ESR and CRP, and there is a visual analog scale. And by this, you can tell whether the patient has high disease, moderate, mild, or the patient is in remission. Now, if a patient comes with a high D28 score, or you have an admission on the medical ward with a lot of pain in a patient who has rheumatoid arthritis, the question is always, is this a true flare-up of the disease, or are we dealing with something else? And this is a challenge that we face as rheumatologists on a day-to-day basis, and I'm sure that you can recall such patients on your wards as well. So there's always a question, is there an alternative diagnosis? Does this patient have a chronic pain syndrome? Is it osteoarthritis? Or is it a completely different diagnosis? Because when these patients develop malignancy or they're brewing an infection, they sometimes present just with a flare of their underlying disease. So these are the things to consider when you see these patients. So, and a very sad but true fact is that although the treatments of rheumatoid arthritis are much more targeted, we are getting better at the treatment, the mortality is still the same. Over the last 50 years, it hasn't changed. So our rheumatoid patients are still dying more compared to other people in the population. And the reason is not their disease, it's not the rheumatoid disease, it's other things. And these are the comorbidities that I want to talk about. So we know that there is an increased prevalence of cardiovascular disease. These patients are more likely to pick up and die from infections, particularly pulmonary infections, and there are certain malignancies which are much more common in these patients. And there's a number of reasons for the cardiovascular mortality. For example, we know that there is axi-related atherosclerosis, which is driven by the pro-inflammatory cytokines, for example, IL-6 as well as TNF-alpha. They have abnormal clotting formation, and they also have an abnormal lipid profile. So in addition to the traditional risk factors, rheumatoid arthritis has additional risk factors for developing cardiovascular morbidity as well as mortality. And this is something that you from internal medicine need to be aware of. The morbidity is obviously increased because of the joint deformities, but also these patients, because of the inflammatory condition, are more likely to develop osteoporotic factors because of the rank ligand pathway activation. This is the study I would like you all to be just aware of. It's the COMORA study, which looked at the number of comorbidities in patients with rheumatoid arthritis across 17 different countries, about 4,000 patients. And you can see a whole array of comorbidities in these patients, from depression, cardiovascular events. An interesting point is that not even they had cardiovascular morbidity, but they also had an increased prevalence of risk factors compared to the other population who don't have rheumatoid arthritis. So this is some of the local data that we have in SKMC. This is the data from an audit that we did last year. We looked at patients who attended rheumatology clinics, and we wanted to look at what is the cardiovascular morbidity in our patients who attend the clinic, and how good are we at recording the morbidity as well as the risk factors and their treatment. And we found that coronary artery disease was present in about 9%, and there was a small proportion who had a stroke or TIA. Looking at the risk factors, about a third had hypertension, about a fourth had diabetes, obesity, and about 50% of our patients. And although we were good at checking blood pressure and BMI, which is something that's done by our nurses, we were not very good at checking the traditional risk factors in our patient cohort. So this is something that we as rheumatologists need to work on as well. So how do we treat this disease? Well, we use disease-modifying drugs, and there are three types. We've got the conventional ones, which is the methotrexate, the sulfasalazine, leflunomide, and hydroxychloroquine. Then we've got the biologics, which are very targeted. And then we have a third group called the targeted synthetic DMARDs. And this is an example of all the disease-modifying drugs. And in addition to that, we use anti-inflammatories and steroids, only to treat flare-ups or sometimes at the beginning of the disease when we are starting treatment. So how do we treat that? We always start with a conventional DMARD, then we reassess the disease every 4 to 6 weeks. And we aim for remission. So we treat to target, and the target is remission or low disease activity. At the end of 6 months, we're hoping that our patients are in remission. If they're not in remission, we can combine the conventional DMARDs or add a biologic or add a JAK inhibitor. If, however, the patient is CCC positive, it has a high ESR and CRP, we can move to a biologic or a JAK inhibitor at 3 months. But that's what we aim for. We aim for remission or low disease activity. So now that, because we are so aggressive with our treatment, there are a lot of challenges that we would see with the disease-modifying drugs, and I'm just going to present 2 cases. So this is a 54-year-old guy with seropositive. He's on methotrexate with a conventional DMARD, and then adalimumab, which is a biologic anti-TNF agent. And he was admitted to our medical ward through the medical take with a 2-day history of being breathless, but a 2-week history of being unwell with a cough. And he got unwell very quickly, and he moved to ICU. And this is what his chest X-ray looked like. So you can see that there's a lot of bilateral interstitial shadowing. It wasn't quite sure whether this patient had rheumatoid lung disease or it was heart failure, but because he deteriorated very quickly, he had a bronchoscopy and a lavage, and his PCR was positive for pneumocystis carinii pneumonia. So he had PCP. This was picked up, and he was successfully treated and recovered, but that leaves me a challenge. Am I okay to start him back on the anti-TNF or not? And this is another patient. This is a 49-year-old lady who presented to the medical take again with being unwell with fever, sore throat, mouth ulcers, only for 2 to 3 days. And then, interestingly, she was diagnosed with rheumatoid arthritis only 2 weeks ago, and she was started on a small dose of methotrexate. You can see that she was a peritoneal dialysis patient, so I don't know why in the first place she was started on methotrexate. But anyways, when she presented, she had pancytopenia. It got worse. You can see on day 3, she had a white cell count of 0.5, and she had no neutrophils at all and a platelet of only 9. And all her immunology was negative. All the tests looking into why she had pancytopenia was negative. So in the end, we thought that it was due to methotrexate. The methotrexate was stopped, and she was rescued with folinic acid as well as steroid, and her white cell and her cell lines improved by the day 7. So in this case, patient had methotrexate toxicity leading to pancytopenia, and most likely it was because of the fact that she was peritoneal dialysis patient. So my take-home message is that rheumatoid arthritis, it's a musculoskeletal inflammatory disease, but it also has systemic features. It has a lot of extra articular manifestations in the musculoskeletal system. It causes symmetrical and progressive arthritis, which can lead to deformity. The multiple comorbidities, especially the cardiovascular And this needs to be considered when you see these patients. The management needs to be treat to target, and we need help from internal medicine physician as well as medical specialties. Thank you.